Welcome to Pedo Teeth Talk, brought to you by the American Academy of Pediatric Dentistry, a podcast show that delivers cutting-edge ideas for the professionals specializing in pediatric dentistry.
Thank you for tuning into Pedo Teeth Talk, where we bring you the contemporary issues important to you and your practice. Brought to you by the American Academy of Pediatric Dentistry. I am your host, Joel Berg. Thank you to our Pedo Teeth Talk sponsor, Hugh Freedy, for helping us bring you great content. We couldn't do this without them. Visit them at www.hughfreedy.com. That's HU-FRIEDY.com. We're here today with Dr. David Carson. He is a dentist anesthesiologist. David has a BS in biochemistry from Washington State University with background in medical bacteriology and virology. Came in handy during the pandemic, I think. At WSU, he researched E. coli and their bacteriophages. His DDS is from the University of Washington. David has 5 publications in the scientific literature. He received the Award of Distinction in Continuing Education from the Academy of Dentistry International. Dave is assistant professor in hospital dentistry at Oregon Health Sciences University and was on the ADA steering committee for the dental licensure OSCE exam. He mentors interdisciplinary lecture group at OHSU, the Tillicum Crossing Seminar Series. He is a chair of the Washington State Dental Commission. That's the dental board in Washington, also chairing the Infection Control Committee. Dave and his residents provide care throughout the emergency dental care clinic throughout the pandemic shutdown. He lives with his wife and his son, Davin, his wife, Sharon, in Vancouver, Washington, along with their dog, Kiki. He has been a member of the spiritual care team at Salmon Creek Legacy Hospital since 2012. During the COVID-19 pandemic, David did 30 lectures, mostly on WebEx or Zoom. He continues to advocate for the dental licensure OSCE on behalf of the Joint Commission of National Dental Exams, most recently at the California Board of Dentistry. Today, we will discuss one of Dr. Carson's many areas of expertise, and I could talk to him about 20 subjects at least that I know of. We're going to pick one today, and that is transitioning patients with special needs from a pediatric dentist to a general dentist, a big problem we face for a long time. Dave, thanks for being with us today on Pedo Teeth Talk.
Hey, great to see you again, Joel. Gosh, the last time we were face-to-face was, we were talking about the OSCE. That must have been about 5 years ago?
So you see, it was about 5 years ago, and I hear it's quite advanced now, and I'm going to go off topic for a moment and start a new thing. Just, you've inspired me. We're going to have like a 1 or 2 minute off topic, okay? And we'll get into the main topic. And the off topic is, update us on this OSCE thing. I mean, a lot of people don't even know what an OSCE is. You could briefly just tell us what's an OSCE, what's going on with it nationally, and it's certainly there real quick.
So OSCEs are used in all of the rest of healthcare. Dentistry is pretty much the only exception, and now it's not the exception. So it means objective, structured clinical examination. And so what we did at the JCNDE and the ADA testing services is created a virtual OSCE that's put on a computer with the intent that it's for licensure. And what it tests is clinical judgment and critical thinking, which I find as a chair of a state board, that makes all the difference in whether people do the right thing. And hey, that's what we're talking about today, doing the right thing for our special needs patients.
That's fantastic. So I'm going to set up a time because I think we need to talk about the future of examination and how we qualify people. I used to always say, you know, if you want to make what counts to us as pediatric dentists and give our influence for all dentists, not just for pediatric dentists, I would have examination of a 1-year-old on the state board exam. So maybe in future OSCE would be, how do you talk to a mom of a 1-year-old and give anticipatory guidance?
You know what? We have questions about pediatrics on the OSCE because it's not just related to restorative, it's related to all of dentistry, including peds.
Okay, so promise me we'll talk again about that. We'll come back.
You got it, Joel.
Okay, so let's talk about the subject at hand, and that is transition of special needs patients. Big problem since for my entire career. You know, we're the mission of our specialty pediatric dentistry is caring for all children and patients with special healthcare needs. And historically, that's meant even for adults in some instances, right? Because parents don't want to leave us. It's kind of like the pediatrician. You know, if a child has special needs, they don't want to leave they get a little tender loving care. We know how to manage them. But then it comes to a point where their dental medical needs go beyond the scope of our trained capabilities. We're no longer a general dentist, even though we were trained as one. We specialized. It's unethical for us to do it. I don't do crowns. I don't do root canals. I don't do perio. So tell us a little bit about your experience as we enter this subject on, transitioning from somebody else to you regarding a patient with special needs.
So through the general practice residency at OHSU, I'm on a panel that reviews patients that are input into our system. Unfortunately, the dentists in practice oftentimes are not trained to deal with people that have any kind of unusual need. They are trained to deal with the average ASA1 or ASA2 patient. And when it gets beyond what they feel is beyond their scope, they want them to send them somewhere else. Unfortunately, there isn't a lot of insurance support for that. People often find that they don't get adequate payment, and it becomes easy to simply send them to the university. And so we have to review the information we get from the pediatric dentist primarily. And sometimes the patients are 23 years old. They've been with this pediatric dentist their whole life. And now they've got to transition to us at a big institution. And I feel kind of bad for them because they're oftentimes, if they have to have GA, for instance, they're behaviorally not appropriate for our outpatient clinic, then they're going to be thrown into a kind of a scary place, and they don't know anybody. And I really don't like that. In fact, oftentimes my preference is that even if we're kind of sure that they need to have the help at the hospital, I'd rather they came through our outpatient clinic and we got to know them a little bit and they get to meet some of the people we have there. In fact, it'd be really nice if we could have an extended time to get them accustomed to us. Unfortunately, oftentimes this is pushed by some urgent need, and then we don't get to have that extended introduction and building of the relationship. And so that's important for the patient and the family.
You want to be their dental home. You want to make a dental home a safe, per the definition of dental home, a safe place that's comfortable.
Exactly. Or we want to see, we have to assess. So that's one of the things our panel does. We try to assess, is this a patient that strictly needs to be at the hospital? Can they be at our outpatient clinic? Or maybe can we do both? And how can we make this most comfortable for them and create a relationship with them? So I would ask that my pediatric colleagues make this a little bit easier for me, even on that level. Let's make this take a little bit longer. Let's give it some lead time, as well as I want to know more behavioral information about the patient. So me as an anesthesiologist, it's that behavioral information, because anesthesia is about modifying behavior, really. If somebody can't tolerate the amount of stimulus that we provide in a dental environment, then the anesthesia is to modify the behavior. And so if that means making them completely insensible or completely into general anesthesia, so be it. But if it means simply sedating them at whatever level, let's do that too. You're talking like a pediatric dentist. Actually,
you're talking about making the way that you, as a general dentist, also anesthesiologist, of course, but take the general dentist part, the way you manage the patient, the same way we would look at the patient as a pediatric dentist, instead of just a one-off or fix this problem. And that's great. I mean, that's music to our ears, but we need to figure out how to get that to be more universally accepted, what you're telling us, that others would see it the same way.
I'm saying it because it's truth, Joel.
Yeah.
That's the way it is that the healthcare relationship is all about a relationship, and it's about trust. And you can't build trust. Well, few of us can build trust in a moment, and especially if it's in a scary situation with unfamiliar people, it's hard. And so there has to be that transition time. So let's set it up so it's successful. So anyway, when I get this information, I want there to be information on the behavior of the patient. What's their history? of why have you decided to treat them the way you have, so that I know where to go from here. I'd also like to know, do you think there's a possibility we could treat them as an outpatient? Or are there some things I'll tolerate? I'd like to know that information. And of course, sure, I want the nutshell of what are their health concerns, but I'm going to find that either on the Epic record or from their primary care anyway.
Right. Yeah, so you've listed a few things that you'd like to see. So I'm hearing that there are some problems with the way you get referrals now. And maybe you could identify some of those and what you'd like to see different about the referral to you, just regarding that.
Well, rather than saying patients always had GA, I'd like to know, why have they always had GA? What kind of behaviors do you observe in the office? Are they combative? Are they just not communicative? Any kind of explanation would help, rather than patients always had GA or patient is nonverbal, which is oftentimes what I get. And I don't blame the pediatric dentists. I mean, perhaps that's their expectation of all we want to hear, and just send them to the hospital. But we would like to see that, could we treat them in a different way? Because I know when they're immature, sometimes you don't have a choice. That's the only way it can be done. But we'd like to see, can we do something different? Is it possible?
Yeah, that's very helpful. And I think there's going to need to be a systematic approach to everything you're saying today, so that others can implement some of your experiences. One of the obvious questions that comes up for us on a case-by-case basis usually is, when do we make this transition? We've seen this patient in many instances. I personally have seen patients for 20 years, starting at age 2 until they're 22. And, we have this problem with typically developing people as well, not just special needs patients. They don't want to graduate because they like coming to our practice. Some of the teenagers don't. They don't like hanging out with the kids with the Mickey Mouse and the slides and all that. Right. They feel like they're being treated like a kid, but many of the parents want to stay, but we need to graduate them, and we tend to hold on to the special needs patients a little bit longer. But even like children's hospitals, when I was at Children's Hospital of Seattle, Children's Hospital, they had a pretty hard and fast rule that when you're over 21, we're not going to see you anymore as a patient at Children's Hospital, period, because they have it for overall. But we would plead to get like a 22-year-old and a 23-year-old, because we have a care team that's not just dental, but other people who are also pediatric specialists. But so the problem's for everybody. But anyway, what's your recommendation on when to start this transition? I think I know the answer, but I want to hear what you say.
Well, it's a little bit fuzzy, but I think a lot of it has to do with the patient's maturity. But also their physical maturity. So with special needs patients, that can vary. So usually what I expect out of a typical patient is that their maturity is going to hit at about puberty. And so that's the time to start thinking about it, is when they hit puberty, when they have physiologic maturity, and we don't necessarily have to treat them as though they're a pediatric patient, say for anesthesia or for drugs. And so then the bigger thing is the behavior. And I think it's also a problem when perhaps this patient that you've had for 20 years is now 6'5" and 280 pounds, and maybe doesn't fit your equipment anymore, and maybe is intimidating to other patients, or maybe loud, or maybe doesn't fit anymore. And I think the thing is that it would be nice for there to be a nice smooth transition over time, where you're trying to create a relationship, and maybe the parents have to visit some different places, or maybe you have to use some judgment about what kind of personality does that practitioner have that I'd like to send them to, and can we make a smooth transition, or even have an alternating transition where it can take a little bit of time and make everyone comfortable, and especially make the pediatric dentist that has that relation feel that they've done the right thing.
Yeah, no, that's good advice. And obviously that transition, that kind of, this is not like overnight pushing a switch. That's the wrong way to go. It needs to be a transition, as the word suggests. We will now pause for a word from our sponsor.
Hugh Freedy is the global leader in dental instrument manufacturing and infection prevention solutions that keep you performing at your best. For more information on Hugh Freedy products, Visit hughfreedy.com/AAPD-crowns. That's hugh-freedy.com/AAPD-crowns. And enter the promo code 2682 if placing an order for pedo crowns.
We're back with Dr. David Carson. We're talking about transitioning special needs patients from pediatric dentistry practice, the complexities of this, how to do it. So, Dave, I want to ask you, to whom should we be sending these patients? I mean, the whole country can't refer to you.
No.
So how do we find out in our local communities, wherever they may be, who to refer to, and what should we do?
I think perhaps one of the early steps is, I think a lot of pediatric dentists belong to their local dental society, and they can talk to people. They can find out who's comfortable with seeing patients. Oftentimes, it's the people that have taken a general practice residency program that's hospital-based, and they're familiar with dealing with anesthesiologists, or perhaps they have hospital privileges. And so I would certainly seek those people out because they will have greater familiarity. I think your average GP may not have that familiarity of dealing with people that have special needs. On the other hand, I would say, golly, we need more training. Golly, we need more opportunities so that people can take care of not just this pediatric transition, but the geriatric transition, where we look at broader special needs. There's a big issue with that, and there are similarities between pediatrics and geriatrics, but it's the same kind of thinking, that we have to have people that can take care and care for these patients that have needs that are other than typical.
Yeah, I think the good news there is I'm seeing, coming from all parts of organized dentistry, including the ADA through CEDL, dental education licensure, through the commission eventually of dental accreditation. We're seeing a push in the last few years only to really strengthen the training at the pre-doctoral and postgraduate levels. So I think that's going to be enforced, what you're saying. So that's all very positive.
I'm looking forward to more of that. But right now, it seems like a lot of people are sent to us at OHSU. And it's not that we don't want to see them. It's just that we only have a certain amount of bandwidth, and we need to spread it around with other practitioners. We have to have maybe other hospitals or other large clinics that are willing to see special needs and have that training. And a lot of it is behavioral training. Some of this is not how do you treat somebody with Turner syndrome. It's can you train your people to understand the behaviors of somebody that's autistic.
Exactly. It's not the condition, it's not the diagnosis, it's the behavior. You're right. How to manage through that behavior.
It's the behavior mostly.
That's right. Yeah, that's very helpful. So you've described a few of the barriers to making this happen. What are some other barriers? Because unfortunately, it doesn't always happen smoothly. There isn't a smooth transition. Patients fall through the cracks as a result. So why does that happen? And what are some other things we can do to fix those barriers? Yeah,
one of the difficult problems is state legislatures not devoting enough money towards taking care of people when they become adults. So apparently it's more persuasive to take care of a child than an adult with special needs. And then how do we do that when the reimbursement is either very limited, absent, or just not enough to even pay the freight? So at OHSU or places like University of Washington, we'll do it. But we've got to lobby our legislatures to take care of everyone, because they're human beings, and it's not fair. It's simply not fair. It's not compassionate.
Yeah.
So I have a lot of respect for my pediatric colleagues about what they've done to try to take care of people, but it's this transition that makes it ugly.
Yeah. I mean, do you think that it relates somehow to the declaration of medical necessity? Because if it's true that what we're deeming to be medically necessary for these adults as well as kids, it's a valid medical necessity. The hospitals aren't going to deny care, or the community is not going to deny care if you have a nose problem or a foot problem if you have special needs. But for some reason, dentistry is easy to dismiss as not medically necessary. Do you think it falls into that category in their eyes?
I certainly think it does. Unfortunately, a lot of times what we're talking about in dentistry is quality of life rather than is it going to cause death. And so if somebody's non-communicative and they've got toothaches, but maybe they're not abscessed, and they can't tell you, but they're uncomfortable. Shouldn't we take care of that? Or do you have to wait until it's abscessed? Do you have to wait until it's a medical necessity where it's going to affect the rest of their health? Or why not? Why don't we just take care of it in the first place?
Yeah, I mean, I think we need to get into this conversation much more and convince based on medical necessity, because, in reality, I think often it's easy for our colleagues and legislatures to think of dentistry as sort of post facto. We're repairing a problem that occurred, and that's too expensive, and it's not necessary, as opposed to the tooth before it gets abscessed to prevent it. You know what I mean? They don't see it.
We both know that leaving caries and having pain in your mouth is going to create a greater disability.
Yes.
And so I especially see that with patients with dementia, and I see that with people with cognitive impairments, is that if their mouth is painful, even though maybe it's not going to kill them, it's going to create a worse problem for them. They're going to have a much poorer quality of life. And if it's left alone, maybe it will kill them.
Yeah, I learned through some of my own experiences that employers who self-fund, self-insure insurance programs for their employees, they actually have a pretty good handle on oral health, and they don't want their employee missing work because of a toothache, because it costs them money. Mm-hmm. When it comes out of their pocket, Absolutely. They're paying the bills. So I think we need to understand that we just need to educate more that it costs society money. If from a financial, there's a human welfare issue too, of course, but and it's quality of life. There's tons of evidence. So I guess that leads to my final question, Dave, in our limited time today. What do you think needs to change? We've talked about a lot of aspects of this. It's exciting to hear that, at least through the health centers and graduate GPR programs, et cetera, AGD programs, we can get some care, but that's not everywhere. And you can't absorb all the burden. So what needs to change to kind of move towards really fixing this problem?
I think, Joel, we need to cooperate to create some protocols for transition. I think that would help a lot. We need to push for, and I think some of it's already happened, the educational programs where we can get people a little bit more savvy about how can you deal with patients that have special needs behaviorally and their medical issues. And I think that we have to lobby legislatures to provide just compensation and make sure that they understand that these people are not objects. And we're treating families. We're not just treating a single person with special needs. This is a whole family, and we're creating a disability for that family. That has a real economic impact. If that's the only thing that legislature is going to hear about, it's about money. Well, this definitely has an enormous money impact on many, many people. And it doesn't have to be that way. It can be dealt with in a compassionate and financially efficient way. But I think it does start with us, the people that are working with them.
Well, Dr. David Carson, thank you so much for being on Pedo Teeth Talk today. You're a wealth of information. I'm so pleased to reconnect with you, and I look forward to our next podcast on licensure exams and how do we test the dentist of the future in a different way. And that's an exciting topic, and I think you'll have a lot to say about that.
I'd love to do that, Joel.
Thanks again. And thank you to our audience for being on Pedo Teeth Talk today, brought to you by the American Academy of Pediatric Dentistry. We'll see you here next time.
Do you need additional CE hours but don't have time to travel to courses? Did you attend annual session and want to listen to the audio recordings? Check out AAPD's new Education Passport. The redesigned and improved Education Passport is AAPD's online learning center, where you can earn CE and listen to audio recordings from all of our continuing education courses and more. Visit educationpassport.aapd.org for more information. For 10% off any product, use discount code TEETHTALK in the Education Passport store.
Pedo Teeth Talk is brought to you by the American Academy of Pediatric Dentistry, the show that delivers cutting-edge ideas for the professional specializing in pediatric dentistry. If you have any questions or comments, please email info@aapd.org. We welcome your ideas for future shows and guests. For more information on the American Academy of Pediatric Dentistry, visit aapd.org.